pretty cool.
All righty. Hello, everybody. For those of you who are starting to log on for the event, welcome to DrugBank in Conversation. This is our first session of our newest webinar series that features industry experts. My name is Erica Navarra. I am the Customer and Community Marketing Manager at DrugBank, and I'm filling in for Chris Klinger today, who is usually going to be your moderator and facilitator. And today we are joined by Dr. Bani Tamraz from UCSF. We're going to give people a few minutes to join, and then I'll maybe do a small round of introductions again to make sure that everybody knows who we are before we get going. All righty. So I know a few folks have joined. If you have any questions or any thoughts, please feel free to put them into the chat window on your on the bottom of your screen there. We'll be moderating and monitoring the chat. So if you have questions, we will try to do our best to answer them later on. But I wanted to give you a little bit of background about what we're discussing today. So when UCSF Health launched their Clinical Pharmacogenetics program, Dr. Tamraz played an integral role in its implementation, leading their team to be one of the first in California to provide drug gene testing, which is very exciting. So in this session, Dr. Tamraz will dive into the implementation and details of pharmacogenetics and what's changed since UCSF started this work. He'll speak to the identification of genetic determinants of drug response through modern methods to address pharmacogenetic research and discuss how it can be used to translate information into new diagnostic treatment strategies at point of care. So before we get started, I will go through our today's format. So we'll have a presentation for about 45 minutes, and we'll use 10 minutes following that for Q&A before we wrap up. So as I mentioned, if you have any questions throughout the presentation, please feel free to pop them into the chat, and we will do our best to address them after Dr. Tamraz's presentation. And this presentation will be recorded and shared with everybody who registered for the event early next week. So before we get started, let me hand the mic off to Dr. Tamraz for an introduction.
All right. Thank you, Erica, for that introduction. And thank you, everyone, for joining us this Friday morning, at least Friday morning, my place, San Francisco time. I'm delighted to be here, and I've been looking forward to giving this presentation to this audience. So just give me 1 second to share my screen and make sure everyone can see the screen. Okay. Erica, does it look okay?
Yep, we are good.
All right. Again, as Erica mentioned, I'm Bani Tamraz. I'm an associate professor of clinical pharmacy and recently appointed director of pharmacogenomics. We just started our program. We did not have this position, and now we have it. I'm the inaugural director of this particular program at UCSF. So I'm very pleased about that. I do have one disclosure. I'm a scientific advisor for a company called Codex Genetics that is in the space of pharmacogenomics and other genetic products. My general outline is I'm going to give some introductory information related to pharmacogenetics, and I'm going to spend the bulk of the time talking about how we started our UCSF pharmacogenetic program, what is it like, and I'll actually share some of the results, some stats with you towards the end as well. So pharmacogenetics is just by definition is the science of applying genomic technologies to determine the effect of relevant inherited or somatic genetic variation on drug behavior and response. And I shared a slide. I want to highlight that our focus right now is on inherited or germline variants, not somatic for this particular program. And as a field itself, it sits at the intersection between genetics, pharmacology, and biochemistry. And just this slide, I'm trying to summarize what's the status of pharmacogenetics as I see it. I would say that there exists a large and growing body of knowledge that's associated with clinical pharmacogenetics. There are technological advances in DNA sequencing, genotyping, and computer that drive this pharmacogenetic demand. There are good pharmacogenetic resources that can help us with clinical practice, but there are challenges to wide use of pharmacogenetics. And there's a reason that it's not the standard of care all over the country or everywhere. And these are some of the challenges. So our healthcare system is fragmented. There are at least more than 800 electronic health record systems in the United States. You know, it's dominated primarily by Epic, Cerner, and so on, but there are so many systems. So how do you get information across to them? That's a barrier. Professional education is another one. Guidelines issued by professional societies, you know, most of them don't endorse this, or we're not on the same page. There's PGX testing is considered a problem, a barrier, because I've heard clinicians saying that, oh, the testing is not FDA approved. Our healthcare system doesn't emphasize prevention so much, although we're making changes in that. We're mostly reactive. Cost effectiveness, limited or lack of cost effectiveness data in support of pharmacogenetics. Payer restriction, that's a big barrier, right? We know that. Turnaround times of the test results. The test, it takes, like for our assay, it takes 2 weeks. So if you're interested in prescribing a patient a new medication, that 2-week turnaround time is not ideal. And it's also, for us, it's actually a little more challenging in some ways, because we have a lot of telehealth that's going on, and getting a patient that's out in the community to do the blood test and send those results and send the sample to UCSF, we're not there yet. So that's a problem. And we have bioinformatic challenges as well. So lots of stuff. I wanted to highlight, like, one of the challenges, as I mentioned, like professional organizations. Like, we've been having a lot of discussions about DPYD testing for oncology. And if you look at like what NCCN says with this respect, and NCCN is the National Comprehensive Cancer Network, their statement is that pre-treatment DPYD testing reduces toxicity and cost, but NCCN doesn't support universal testing at this time. So, and the rationale is DPYD guided doses for each variant are not sufficiently precise. Other variables affect pharmacogenetic systemic concentration of medication, particularly for capecitabine. DPYD guided dosing hasn't been proven to be similarly effective in randomized clinical trials. And so that's their rationale for their recommendation. And FDA states that it informs patients of serious adverse reactions and discuss whether they should be tested for DPYD and consider testing for genetic variants of DPYD. And their rationale is no FDA approved DPYD genetic test is out there, unknown rate of false positive or negative results with clinical consequences. So NCCN doesn't recommend routine testing. So this is this kind of language, and this with respect to DPYD testing, it causes some confusion, I guess, and not everyone is on board for this. So these are some of the reasons. I did a few years ago, I did a survey of our clinicians across different services where they were prescribing medication that had pharmacogenetic evidence. They had CPIC guidelines. These are primarily level A and level B drugs. And and I'm sharing this data is because, and I've highlighted some, and you can see like cardiology, when asked, like, out of 8 cardiologists, have you used pharmacogenetic in the past 12 months? That's the first row. And they said no, these 8 cardiologists. Are you interested? 8 of 8 said yes. But then when you ask, is observational data okay? Only half of them say observational data is sufficient for using pharmacogenetics. And you'll see these kind of statistics across the different services, and for pharmacists and physicians alike. And and if you recall, when we were looking at NCCN, that's one of the reasons as well. They want to see randomized clinical trial. And this is another challenge that we face, is that, and I'm giving you this example of simvastatin, looking at different drug reference resources that clinicians can go to. So if you're looking at simvastatin and SLC01B1 star 5 testing, if you look at the package insert, there is nothing in there about the SLC01B1 testing. CPIC, that's the Clinical Pharmacogenetic Implementation Consortium, obviously has recommendations. Lexicomp also has recommendation, and this is the wording that they have: due to increased risk of myopathy, consider a lower dose for patients with, and they give you specific RSID. This is a SNP ID. That may be hard for some clinicians to understand and know that this RSID is referring to that star 5 allele. If you go to the FDA PGX table, they use that 521TC or 521CC. Those are, again, the position of specific nucleotides within the DNA that refer again to that star 5 allele, and they say that results in higher systemic concentration and higher adverse events. The risk of adverse reaction is higher for patients on 80 milligram than for those on lower doses. And then micromedics, no mention of PGX for simvastatin. So again, some of these issues make it challenging for clinicians to adopt and use this information. So that's with the challenge. I'm going to stop there because obviously we're doing it, and there are a lot of people that are using it, and we're coping with some of these challenges. The other side of the coin is that it's good to remember and keep in mind that actionable pharmacogene variants are common across populations. There have been several studies. UK Biobank did a study that was published in 2020 that showed that out of almost 500,000 members that they have in the UK Biobank, only 99.5% had a variant, actionable variant. And then there was a study that came out of Hong Kong in 2021 that showed that 99.6% of individuals had an actionable pharmacogene variant. And both of these studies, they have additional data that shows, like some of the information that I've included in here. So like in UK Biobank, you can see says 23.7% of participants were prescribed a medicine on CPIC list. So but the overall message in here is that these variants are common. So if you're seeing a patient, and that's there. And then the last number you see, the 100% in red, that's out of 182 patients that we've genotyped. This was as of last week when I looked at these numbers. 100% of our patients have had one actionable pharmacogene variant on the 15 genes that we are genotyping. So that's important, again, to keep that in mind. And then while there are lots of clinical validity studies out there, there was a recent publication in Lancet, and I realize it's gotten some criticism, but this was a study that was published earlier this year in the Lancet. There's a European study, looked at 12 pharmacogenes, and they reported, again, this was looking at 7 different countries, they reported that within 12 weeks, they saw a 30% reduction in incidence of adverse events in the groups that were genotyped compared to the ones that were not. So there is some evidence of benefit, a reduction of adverse drug reactions as well. So with kind of that background, so let's dive into the UCSF pharmacogenetic program. So we put together a multidisciplinary team that kicked off this effort in September of 2021. Our teams met weekly. I was on so many different teams. I met daily, but overall the teams met on at least once a week. And we worked very much on identifying drug-gene interactions of interest, working on setting up our lab, developing our EHR system, and putting together our educational content. And so, as part of that effort, we engage various stakeholders. 35 leaders across various services were engaged, and I'm listing all these services in here. That were approached and notified that this is something that we're working on, and they had input into this. Okay. And then I personally have attended 19 different stakeholder meetings and discussed in details all of these our activities and report it to these different services as to what's coming. And I would say my general impression was that there is an overwhelming support for instituting pharmacogenetic testing at UCSF. So I think that top-down approach was really important. In terms of identifying drugs, as of last year, FDA has a table of pharmacogenetic association. There were 335 different therapeutic drugs that carry some type of information specific to pharmacogenetic biomarker, and they fall, majority of them are non-oncologic. And then we relied a lot on CPIC. So CPIC is, I mentioned it already, it stands for Clinical Pharmacogenetic Implementation Consortium. This is an international consortium of experts in pharmacogenetics and medicine. We're committed to using a pharmacogenetic test to improve patient care. They basically review literature with regards to specific drug-gene interaction, and then based on that, publish guidelines, clinical guidelines that clinicians can use if pharmacogenetic information is available. And they divide the recommendations based on they assign different levels, like level A, B, C, and D. Level A drugs recommendations are based on drug-gene interactions, where CPIC says if genetic information is available, this information should be used for prescribing. And then level B says if genetic information is available, this information could be used because alternative can be as effective and as safe. So based on CPIC and FDA, we came up with this list of genes and drugs to start with. So we had 62 drugs and 15, genes that you see in here. And so this was our list, and we started working on building our clinical decision support system based on this. And most of these drugs in here are CPIC level A drug. Again, we chose those because at least there's a lot of evidence behind the use of genetics in that. And so if you take the FDA recommendation, those 335 drugs that FDA has on its list, and break them down by different therapeutic area, you can see that almost every therapeutic area has at least a medicine that is impacted by genetics. And the numbers in parentheses that you see in here are referring to our medications and where do they fall within that. And the table that you see on the right is that it says meds not on FDA list. These medications, FDA doesn't have any information on those in that particular, on genetics in that particular table, but however, CPIC does, and all of these medications are included in our program. So that's that. And of these medications, 62 medications, we had 118,663 unique patients that were prescribed at UCSF, one of these 62. And so this was an impressive volume. And as we set up our lab, we have capacity to do 5,000 patients a year right now. And so and I'll tell you how we were going around that. So we went live on May 9th in 2023, and we went live with 56 drugs and 15 genes. And the reason we didn't have 17, because HLA-A and HLA-B testing, we're almost ready to launch that here at UC. So there are like 6 drugs that are impacted by that. So we'll go live with that hopefully pretty soon. And we received a lot of press attention, which was great. So this was the list of medications that we actually went live with. Basically, it's the list that I just shared with you minus the HLA. And the medications that you see that are in red, we built pre-test alerts. This is, again, to control that volume. So if any of these medications are being prescribed now, the clinician receives an alert prompting them to order pharmacogenetic tests if they so choose to. So, in doing so, again, we hope to control that number of orders that we can receive, because again, we don't have the capacity to do 100,000 patients. So we have 15 pre-test alerts, and then we have 56 post-test alerts. So if a patient gets a genotype, if they have actionable information available, all that information can be used for all the medication, for all the 56 drugs. So, which is the nice thing. So you just want to do that first test. And this is an example of what a pre-test alert looks like. So if a clinician is ordering simvastatin, they get an alert that says, like, SLCO1B1 phenotype is associated with increased risk of statin-induced musculoskeletal symptoms. Consider ordering pharmacogenetic testing to guide your treatment. Turnaround time is 2 weeks, and necessary medication should not be withheld while waiting for genetic test results. And the clinician can decide to keep their order or remove it, and they can decide to order the panel or not. If they choose not to order the test, they have to select an acknowledgement reason as to why they're not ordering the test. But they're, it's completely up to them. And I emphasize this necessary medication should not be withheld while waiting for genetic tests. So, we just want to make sure that they don't hold the treatment if waiting for the pharmacogenetic test. So once they hit the order key, a window pops up like this, and they have to select indication for ordering. Basically, they click on there, and then they see the drop-down menu that has all the drugs, all the 62 drugs. HLA are there, but again, we're not ordering. They'll see all of them in there, and they select the drug that's driving the test. And once they hit order, they automatically order a blood draw that goes with that. That blood draw has to take place at UCSF. Again, like earlier when I said, like we have telehealth medicine, and so for community, if a patient is out in the community or outside the city of San Francisco and reaching UCSF is not, it can be a problem, then that's unfortunately, that's a limitation that we have. And then once they click order, there's a window that opens up that they need to select a diagnosis. So we send in this ICD-10 code along with the CPT code these are for billing purposes. So we emphasize for our clinician to make sure that they select the right diagnosis for this. And then voila, and they send the order. And so if you are a pharmacist in the inpatient setting, and the test is available for inpatient and outpatient, and you're, if a physician has ordered warfarin, a pharmacist in this orange band right here, they will see if the physician decided to order pharmacogenetic testing or not. So if you see, like in this case, it says single order, that means the clinician ordered a pharmacogenetic test with this. If the clinician had decided not to order it, that they had to select a reason for not doing so, that reason would be displayed for the pharmacist as well. So I think this part is great because our pharmacists get to see what's taking place with respect to the order. So that's our pre-test side of things. Now, once the test is done, we're moving to the post-test alerts. The post-test alerts, they have unedited CPIC or FDA recommendation in them. I personally have drafted them. There are like 348 of these post-test alerts. And then these post-test alerts are presented as medication interaction warnings, and I'll show you an example of these. These alerts, they appear in the meta-interaction warning window, like drug-drug interaction and drug condition interaction, each time a clinician clicks sign for a medication order with a relevant drug-gene interaction for that patient. All medication ordering clinicians, no matter if they're using treatment plans, therapy plans, or managed orders for order entry and signing, see the same alert at the same point in their workflow. Clinicians not involved in ordering, signing, or medication order can also see the same alert in the med interaction warning window when releasing orders or verifying orders. And this is an example of irinotecan. If it's being ordered and the patient has an actionable phenotype, the clinician will see this the pharmacogenetic warning, and they can decide to act on it and then if they'd like to override or proceed forward, they can select a reason. The selection of reason is not mandatory. They can just click override and sign and they will move forward. But for pre-test alert, it is mandatory. For this one, for post-test, it's not. And the nice thing is that if the clinician takes an action on that, and then like a few weeks later, someone else is seeing the same alert, because the alert will fire for another clinician, and the clinician will see the action that was taken by the last provider for this particular order. So that kind of keeps that chain of communication going, which is great. And the pharmacy side of things, if a pharmacist is verifying an order, they'll see, again, this happens in the inpatient, voriconazole, they'll see this pharmacogenetic warning in the bottom right that's I've highlighted. And then they also see, they can click on that, or they can go to the interaction warning, and then they will open up they can click on it, and they'll see a window like this and says, oh, there's an over interaction, but it was overridden by Dr. So-and-so. And a pharmacist can evaluate, this particular order, taking into consideration the patient and the action taken by the physician. So that's really great. As I mentioned, these alerts, I drafted the first alert, draft of all these BPAs, but I engaged 38 pharmacists and physicians across all of these services who actually reviewed the medications that were pertinent to their service, which was great. Got a lot of input. And then these alerts were built. And the ordering of the test can take place in two ways. So the best practice alerts that I just mentioned, that clinician can order, but the clinician doesn't have, we don't have the best practice advisories for every drug, but clinician, if they decide to order for another drug, they can do so. They just go into, find the ordering location in Apex or Epic, and then they type in any of these words that you see in your pharmacogenetics, PGX, PG. They'll pull the order set, and they can order it. By the way, at UCSF, we call Epic Apex. It's just a UC thing. Yeah. So once you order the test, genetic test, so this test is available inpatient, outpatient. The sample is primarily blood. We do buccal swabs only for bone marrow transplant patients. The lab that does the testing is our UCSF Genomic Medicine lab that's located in Mount Zion. We use a pharmacoscan array for genotyping. Our turnaround time is 2 weeks from the time of receipt of the sample. And PGX test results are sent back into patients' Apex profile and in a genomic filters under labs, and report is also created for patient to view in MyCharts. This is our pharmacogenetic data flow, which is our automated pipeline. Again, this is a customized pipeline that we built in, spent a lot of time and effort, and we're very pleased. It's working very nicely so far. And everyone, there's a lot of work that happens in the background, but clinicians, and they put their order in Apex, they'll get the results back in Apex, and they'll be available in MyChart for clinicians, and for patients to review as well. So we strongly believe that successful clinical PGX implementation is driven by automated CDS, and I would imagine most of you will agree. PGX results in Apex, this is what it looks like. So if you go to Apex, you can see these genomic indicators that are, for a patient that has been genotyped. They're all listed in there. And then there is a PDF link that a clinician can click and see a PDF report, as well as several pages long. It's embedded in there. They can read it. So in terms of education, we have provided educational content, tip sheet, training material for clinicians. CPIC has these YouTube videos for 46 medications that we've actually put links for them in a document that we've created for our clinicians, and the clinicians can go watch the videos that are relevant to the medication that they're interested in. This material was all sent to all clinicians in an announcement from our UCSF leadership. We have a pharmacogenetic consult service as well that can be reached, Monday through Friday. We have a one-day turnaround time to answer questions. And then in addition to that, I just want to give a shout out that there are all these other educational content that can be accessed by clinician. NHGRI is one of these resources, and also Genomic Education Resource Center, Genome Ed is a great place to go. If you go, just a note on Genome Ed, it's an online repository of genomic educational material. It's peer-reviewed, that's important, collections for genetic counselors, nurses, pharmacists, physician assistants, and physicians. Professional editorial board curates every resource, and resources are mapped to discipline-specific genomic competencies. You can go to this, to the Genome Ed resource page, and you can search by topics. So you can go to the topic. There are all these drop downs, and you can see like pharmacogenetic is there as one of these topics. You can decide on what kind of a format you'd like this information in, and they're there. And then is this a CE or no? You can select that, and then you get a list of resources that you can use. In terms of genetic competencies, I think this is also a very good place to go and look at what are the genetic competencies that for different disciplines that would be good for a healthcare professional to have. So I recommend visiting that and taking a look at the lists that are listed in there. So who pays? UCSF will bill the insurance. So payment, like I said, is a big, question mark when it comes to pharmacogenetics. It's a barrier. UCSF will bill the insurance. Outside copay, the patient, we expect, will not be responsible for the balance. And we're following this model that we've had for another testing, genetic testing that we have. It's called UCSF 500, which we've done like 5,000. We do 5,000 tests a year, and this is for tumor genetics. So what UCSF does is that we collect what insurance gives us, and we do not pursue patients for remaining balance. And that's been the model for that, and we've implemented that particular approach for the pharmacogenetics. And I'll share with you some of the information that I have on this. So we bill insurance only once for the drug gene pair that initiated pharmacogenetic testing. All future uses of the data is free to the patient and insurer. And I wanted to share with you this. There's a legislation in California. In California, it's called Path for All Act, AB 425. It was introduced by Assemblyman David Alvarez, and if passes, pharmacogenetic testing will be covered under Medi-Cal program for medications known to have gene interactions, and as defined by FDA or CPIC. And so Medi-Cal is our state-funded healthcare system, and we have about 14 million Californians use this particular program. So I had the opportunity to speak in front of the California Health Assembly in support of this particular bill. So I'm really excited. There's a lot of motion and activity. So the bill passed the Assembly, and it has just passed the Senate. It'll go before the governor sometime this fall, and we'll hope it will pass. In terms of variant reporting, we only report variants that are actionable. So unknown VOSs or variants of uncertain actions are filtered out. And I share this particular table in here with you because we were able to get reference samples for not all the variants that are of interest to us. So while our turnaround time is 2 weeks, if we detect a variant, on this example in here I'm sharing with you is like CYP2C9*16, we did not have a reference variant, so it was not part of our initial CLIA validation. So once we observe a patient that has this *16 variant, we will go ahead and do Sanger validation before releasing this data, and this will result in longer than 2 week turnaround time for certain genes. So far, we've had to do Sanger validation for 4 alleles in the last 2 months that we've been doing this. In terms of patients, patient consent is not required, but providers should discuss the test and document discussion and patient approval. This assay is not used for any disease diagnostic purposes. Patient education material is available, and patient can read that. Providers can provide it to them, and they can see it in their report. So the lab report that is in my chart has 2 pages of patient education material that they can read through about the test. And patient can access that, obviously, the results in my chart. So here are some numbers that I wanted to share with you so far. So number of orders completed, we've had 213 orders that we've completed so far. So number of in the last 2 months. So number of pretest alerts fired. So remember, we have 15 drugs that trigger pretest alerts. We have 5,990 pretest alerts that have fired. The ordering rate is 2.9%, and pretest alerts per patient fired is 2. So each patient on average has gotten 2 pretest alerts that have been fired. And you see a number of unique patients that have got, this alerts have fired for is over 3,000. So, these are like raw data. I'm being completely transparent in here. Obviously, we'd like to improve that. 200, out of 2.9% ordering rate is on the low side. So we have rooms to go, and we're working on figuring out how to get more tests done. Reimbursement, like I mentioned, it is something that we're all interested in. I will say that this is outpatient. So inpatient has a different billing model where, but for outpatient, it's reimbursement are more important. So out of 39 so far, the bills that have been sent to the insurance, 22 have been reimbursed. I've just got these numbers like 2 days ago, and I've added them in there. So, so we have 56% or so reimbursement rate. That's the number. So continue with some of these stats. So these pretest alerts, looking at what are the medications that are triggering these pretest alerts. You can see tacrolimus is the one that has the highest number. And the reason for that is that tacrolimus is ordered every day. So the lab, if patient is on TAC at UCSF, we check the lab, we place a daily order. And the pretest alerts, the way they're designed to fire is that they fire once per patient per provider. So if a provider is ordering tacrolimus today, they decide not to order the pharmacogenetic test, they will never see that pretest alerts for that patient ever. That's the way this system is set up. But because TAC is ordered, then tomorrow, another provider may be ordering tacrolimus, they will see that alert fire again for that particular provider. So that's why we have such high numbers for tacrolimus, and then clopidogrel is next, and warfarin. So for 14 out of our 15 drugs, we've gotten pretest alerts that have fired. And this is number of medications for which we have received orders for. So tacrolimus, we've had, out of those 213 orders, 75 were tacrolimus related, 25 were clopidogrel. And then, so the red drugs that I have in here are the drugs that have pretest alerts. So we have 15, but those, we've had 1, 2, 3, 4, 5, 6, 7 of those, 15 pretest alerts that we have and they fired for 14. So they've resulted in order. But it's interesting to me that a lot of these drugs that are not on our pretest alerts, they have, resulted in orders, which is really, really great. So we'll be, again, looking at these numbers and trying to see how we can improve it. And we'll look at usage. We've got several different projects going on, looking at various aspects of all of this. But I wanted to just share with you some raw data in terms of our pharmacogenetic results so far. So the advantages of this UCSF pharmacogenetic testing, we feel that is that it's a UCSF team that has developed this in-house test with strong emphasis on developing an extensive, customized, robust pipeline and analysis process with clinical input. This is a one-time test. Once completed, the test can be used for all future encounters. The gene of interest can be investigated further on request, and I say that because we're only reporting back some select variants on a given gene. So we're genotyping a lot more variants within a gene. So if a clinician wants to look at some of the additional variants, I've had one request so far to look at a couple of other variants, which we've been able to do, which is great. All billings are handled through Apex. There is no need to complete any prior auth. Only patient insurance is billed for this service. At least, that's our approach so far. Pharmacogenomics, we think it can make care safer, more effective, and more affordable. Put that on a question mark. I think it can, but we need to get data to back that up, and we'll be working on demonstrating that, hopefully within UCSF, for patient by helping tailor their medication therapies. And then lastly, it's important to keep in mind the role of genetics. Drug response is really complex. You have environmental factors like diet, smoking, physiologic factors like age, disease weight, pregnancy status, gender, drug interactions, or biologic factors like microbiome, metabolism, and genetics. All these factors play a role in drug response. So genetics is one of many, many factors that does that. So it's important to put things in perspective. And lastly, I'd like to, I'm one member of a great team that has been working diligently on putting together this particular project. This project was under the leadership of our Chief Health Informatic Officer, which is Russ Kachina, and Alex Rajkovic. He is the Chief Genomic Officer. So they were the two champions of this particular project, along with Lisa Kroon, who is the chair of my department. So they were our champion. Without them, we could not have gotten this far. And I think I'll stop here and open the floor for questioning. Thank you so much for your time and attention.
Thank you so much, Dr. Tamraz, for all these insights. This is great.
Sure.
We have a few questions from folks here, so maybe I'll just start rolling through those.
Sure.
So our first question is, this person is curious if there is a reason for the blood test versus swab for PGX testing.
So blood test versus swab. So the blood test, so swabs are not, they don't, we have higher failure rate with swabs than we do with blood tests. The DNA that we get from blood is a lot, performs better on the arrays. We would like to have saliva, but tracking kits and stuff, it makes it complicated. So blood is easy, but we'd like to expand to that. But for buccal swabs, we've only limited that to our BMT patients for obvious reasons.
Lovely.
That answered the question.
I believe so. Dr. Tamraz, do you mind removing the presentation from your screen, and then we can continue with the questions? Sorry about that.
No. Let me stop sharing. All right.
Perfect. All right. The next question. What are your thoughts on the lack of standardized PGX testing and how it will impact results and adoption by all providers, and maybe potentially insurance coverage as well?
Yeah, so that's a challenge. The lack of standardization makes it really, really challenging. There is no standard set of variants that you're supposed to genotype for a specific gene. And so that, I really think it's important to work towards some type of a standardization. That's going to increase the confidence of clinicians for sure in the tests that are out there. Let's see, did I answer all the parts of that question? Was that the only one?
Yeah, I think so. Hopefully, Behnaz, that answers your question. If you have any other thoughts, feel free to pop them in the chat.
Yes, if I didn't answer your questions, please just let me know. Let's see, what are your thoughts on lack of standardization?
So that's that one question there. Maybe I'll move to the next question really quickly, and we can pop back if there's any thoughts. But the next question is, how much do you bill insurance companies for your test?
So for the billing structure that we have is we use the CPT codes for each specific gene, drug, for each specific gene. And so that's why the way this is structured is that, you pick a drug and you pick a gene and then you put in a diagnosis. So for these CPT codes, they vary. You can see the result. You can find the values. They're like I think anywhere from like $160, $70 for CYP2D6. The number is the highest. It's a little over $1,000. These are the CPT codes that we have. That's what we're following. I really hope that we can have a standard single price that we can bill. And there are CPT codes for panels, but panels don't get reimbursed. The reimbursement rate, it's our understanding, is very, very poor for panels, but it is good for single genes. So that's why we've structured it this way. But I really think that some of these prices are there because of past approaches to genotyping alleles like CYP2B6. The assay that we use right now, it doesn't cost us a penny more to look at it. But VCourse1 variant, single variant, and like CYP3A5 or vitamin K epoxide reductase, or CYP2D6, the cost is the same, and it'll be great to have a lower cost for running the panel for everyone. But those are the numbers. We just build the CPT codes.
Gotcha. Okay. Our next question. So there's a question about the different sources of PGX recommendations. So different healthcare systems or hospitals may follow different approaches in order to harmonize therapeutic recommendations between different sources, whether it's the FDA, CPIC, et cetera. What can be done to bring more uniformity?
Yeah, that's a good question, Marisol. Yeah, having moving things towards some type of a uniform standard recommendation should be a goal. I share with you, looking at those resources that clinicians have access to, like Lexicon, Package Insert, Micromedics. There's the recommendations in there are all over the place. They're not consistent, and I think we as clinicians should be working, and we have an opportunity to work and try to bring and harmonize some of this, and so we're all on the same page, because without that, it makes it really, really challenging. Again, like for our, I had like DPYD testing was on the pre-test alert for us at UCSF. I had put it in there, but we have some oncologists that have strong feelings about that, and we took it away from being a pretest, from firing a pretest alert, again, because of some of these lack of standardizations. And so, but we still get orders. So there are some clinicians that order the drug without that pretest alerts. So we have our, it's going to take some time to kind of harmonize these, but I think that should be a very important step.
Thanks for the question, Marisol. The next question is, if a patient moves from the UCSF system to a different one, is it possible for them to use their PGX test results?
Yes, they can take their report and take it with them. Absolutely.
Awesome. And then a couple more questions here. So are there any plans to expand this service to other UC sites?
Well, so yeah, we are thinking about it. Yes, we'd like to. We have 6 hospitals. UC has 6 different UC hospital systems in California. We'd like to do that, but we're at this point. I mean, that would be a long-term goal. At this point, we're not able to genotype all the patients within UCSF. So. Volume is great, getting to a point where you have a good amount of volume coming into a lab. I think that's going to help drive the interest of our leadership at UCSF, and also will drive the cost down if you're running a higher volume. But I don't think there's a need. I'd love to see like UCSF become a hub, our lab become a hub for all these UC centers, sending their samples in there. We'll genotype them and send the data out. I don't see why we could not do that. We could, but it's going to take some time. And I think at the end, everyone will win, because they don't have to invest in setting up a lab, building instruments, and maintaining it. One place can send the data for all.
Awesome. And it looks like we have a couple more questions here. So this question comes from Chad. It says, it looks like you are using the PharmacoScan assay for testing. How are you handling the data from non-reportable/actionable genes? And do you have a discovery slash research arm of your program?
Yeah. So, Chad, good question. So if there are, so we're only looking at variants that we could validate and we could report. They have if you're familiar with that allele, they have the best. What is it? They have there's a special terminology that Thermo Fisher uses in the in Axiom analysis suite for the probes. It says the best and recommended probes. So we only focus on variants that have the best and recommended probes for them and are reportable and for the assay. And do we have discovery and research armor program? We are working on setting that up. I do have some projects in the pipeline with students at this point, but absolutely. We're only reporting a subset of these variants. There are a lot more on the array that we're not reporting. So I hope I answered your question.
Yeah, Chad, let us know if you have any follow-up.
Chad, let me know. And if you have any more questions about the PharmacoScan array, just feel free to reach out to me. My email is bani.tamraz@ucsf.edu. Feel free to reach out to me, and with any question, I'll be happy to help you. I've been involved in all aspects of this, from A through Z. And I've spent a lot of time in the CLIA validation and reference samples and genotyping and looking at that data. I personally looked at over 5,000 calls myself.
So just a few.
Yeah, just a few. Yeah. I have a lot of experience looking at that stuff.
Yeah, we'll be sure everybody to share Dr. Tamraz's email in the follow-up. We have 2 more questions, and that's probably all that we have time for today. But maybe we'll start with this one first. Do you think that we'll see a rapid development of pharmacogenetics in the near future?
I hope so, but it really, I think, like, if we have a bill like AB 425, if it's passed in California, that would be a great step in the right direction and will lead to increased number of tests in California. But until there is, some of these barriers are handled, like some, reimbursements are well defined, and our electronic health systems are synchronized, so you can get this information to our clinicians in a timely manner. If our clinician education is an important component of this, if our clinicians feel comfortable with prescribing this, I just shared with you the results at UCSF. So we have 6,000 alerts fired, and out of those we have 213 orders. Within UCSF, with all the resources that they have, I think the order can be improved, and it's not there. So I feel like it's gonna take a little bit of time to get there, but there's a lot of work that needs to be done in the interim. Lots of optimization from lab, from electronic healthcare system. We need our professional organizations to adopt and this kind of information and make that as a recommendation. And so it's going to take some time to get all of these things done. But I think that we're moving in that direction. So I'm optimistic.
Yeah, one step closer.
Yes.
Yeah. So our final question is, do you cooperate with European countries in providing pharmacogenetic solutions?
I have not. No, I haven't done anything like that yet. But I'm open. I want to work with anyone that's interested in pharmacogenetics. There's lots to be done. I'm very much interested in working on various aspects of this to make that available. I really, when I was talking to our state lawmakers, I use this example of pharmacogenetic being as a seatbelt. It's like, when you sit in your car, you put a seatbelt on. You don't think about putting a seatbelt on, is that a cost-effective activity? I mean, it's the law. This is what we do. It became a law. And there was no cost analysis that was done for that particular activity. So I think having a pharmacogenetic panel results, it is like getting a seatbelt and putting it on in terms of your medication needs. And the technology, it makes it really easily available. And honestly, in terms of cost, it is not that expensive to do the testing. It's so it is within reach.
Yeah, I really like that metaphor. We'll have to use that in the future. That's great. All right. I think that's it for all of the questions. Thank you so much, Dr. Tamraz, for all of your insights and for sharing how UCSF is tackling implementation of pharmacogenetic testing. That was really great and really insightful. So we appreciate your time and appreciate all of your team's efforts. You can probably see in the comments, everybody is thrilled and very thankful for all of your time and energy. Thank you all for attending. To all of our folks who are online, thank you for sharing your time with us. This webinar is recorded, as I mentioned, and it'll be shared with everybody via email probably early next week. And you'll be able to watch this on demand. And for anybody who is joining us virtually, I guess, after the fact, this will all be recorded and available through DrugBank. So if you're interested in any other webinars or any other resources, please follow us on LinkedIn or visit drugbank.com. In the meantime, stay tuned for future webinars. And that's all for today. Thank you, Dr. Tamraz. We appreciate it. And all the best to you and the UCSF team.
Thank you so much.
Thanks, everybody.
Bye.